So to try to fix those slips, we developed a coordinated program with our jointly owned home care agency to look at patients at the time of discharge, see what was happening. We assigned a nurse practitioner in the hospital to work with the nurse outside the hospital and coordinate the services that a patient would receive. We identified any patients who came in right in the emergency department, took definitive action, and were often able to take care of an episode and not cause a hospital admission. So we saw our readmission rate reduced from 18 to 8%, which was really quite astonishing. And our average length of stay decreased from what was actually higher than the national norm to the national norm, which actually beats the regional norm. So we did quite well there. This was an intensive interaction between two sets of providers. The data that were given back and forth was on paper or by telephone. A couple of years later, we were lucky enough to receive a grant from the state under the HEAL program to start our first regional health information organization, which is entitled BHIX, the Brooklyn Health Information Exchange. It had to have an X because everyone in the state says it. But it is BHIX, easy to remember. And it was really started as a partnership among several organizations, really representing the different levels of care a patient needs. And I say that because it's so distinctly different from the way other RIOs were organized. Other RIOs around the city were really interested in patients who hopped from emergency room to emergency room. We said, our patients really receive services from all of us because they need services from all of us, and we need the information. So we started with a couple, actually a few acute care hospitals, Kingsbrook Jewish, Lutheran, Maimonides, Metropolitan Jewish Health System was a member, as was the NSNY 1199 Benefits Fund as a payer was a member, and Sephardic Nursing Home. In that very first group to start the Brooklyn Health Information Exchange. Since then, we've received several additional state grants, and we've seen it grown from that original cluster to include a lot more hospitals and a lot more community-based organizations, and I'm going to talk about them in the context of the next couple of programs that I'm going to describe. The first being our Safe at Home program, which I think is particularly pertinent to the population we're talking about right now. And the goal here was to identify patients who are frail, who are elderly, and who are at the greatest risk of not being able to stay in the community, to work with them intensively at the time of discharge and post-discharge to make sure that all of the resources necessary for their care could be mustered and brought to their disposal. And it was really based on a model created by Mary Naylor at the University of Pennsylvania. It worked quite well, again, initially on paper, but when HEAL 5, I think we're up to HEAL 18, but when HEAL 5 came along, we were awarded a regional grant, actually through BHIX now, which is we've spun off as an independent, not-for-profit organization serving all of the providers, to do a proof of concept that we could support this Safe at Home effort using health information exchange so that data could be, in fact, shared among the home care providers, physicians taking care of patients, and now we are linking private physicians into this as well, and hospital staff. So data are being shared, information are being processed through an organization called Active Health that actually takes data, runs it through what they've called this care engine, which is made up of lots of evidence-based clinical decision rules, and tell providers, okay, your patient's on this medication and this medication, perhaps you should do X, Y, or Z test, and actually have the ability to go through the data and see if that test was performed. that is a project that's underway right now and is sort of reaching further and further out to the community. The next project, we're about a quarter of the way into right now, and this is one that's really particularly near and dear to my heart. It's actually, I think, the most exciting thing I've done ever. And I haven't done it, I'm just cheerleader for it. But when HEAL 10 came along, based on our experience with HEAL 5, the state said, let's have a proof of concept that the use of information technology and information exchange could really make a difference in the care of patients with chronic disease. So all over the state, people put together projects, and everybody picked diabetes because that makes sense. You could demonstrate a change. You could really make a difference that was really important for that group of folks. So we said, oh, we're not going to do diabetes. Instead, we picked schizophrenia because I couldn't think of anything more difficult. All of the care had to be done in the context of a patient-centered medical home, and we said we would actually define a counterpart to that, mental health home, for the care of this group of patients, and because I need a place to reside when the project was completed. And we are well into that process right now. We have defined the mental health home, which is really very exciting, and again, I think really speaks to Freda's point. It is absolutely patient-centered. I'll backtrack just a little bit. Several years ago, we were approached by South Beach Psychiatric Center, the state mental hospital in Staten Island, to assist them in providing the general care services for patients discharged from the inpatient facility and being followed in their outpatient sites, which are in and around Brooklyn. There are 10 of them. And we said, that'd be great. We'll establish our clinic right inside your clinic, and we'll have our staffs work together and take care of this group of patients. And it worked very, very well. We had joint care planning conferences. They shared information that they still do on a daily basis, and coordinate the care of this group of patients who is an exceptionally needy group. I don't know if anybody knows, but patients with severe mental illness, schizophrenia, schizoaffective disorders, bipolar disease, tend to die 25 years earlier than their counterparts without those conditions. It is a population that is very needy and very poorly served. So we were really pleased that we were able to do that with South Beach, but the problem was, and again, Freda mentioned this before, it's not so easily scalable and replicable. You can't always co-locate all of the providers in one place. So when HEAL 10 came along and we said we would do this with schizophrenia, we said, we'll base it on the South Beach model, but instead of real co-location physically, we're going to virtually co-locate them. And we've sort of defined this mental health home as kind of an umbrella that travels with the patient. And in the center of that umbrella is a primary care provider, a mental health provider, a therapist, and a care navigator to really coordinate services. And then wrapped around that inner circle are all of the other agencies that are necessary to care for patients. And this was a big leap for us in terms of conceptualizing what could happen with information exchange and really reaching out into the community, because now we've got lots of agencies providing social services as well as traditional medical providers. We started originally with the major providers of behavioral health and general care services. Now we've got everybody from the Jewish Board of Family and Children's Services and CUCS and PSCH and the whole alphabet soup, right to the discharge unit from Rikers Island to make sure that when patients are discharged that they get into the services they need. Well, this is really exceptional if you think about it, because now we're not just talking about medical information. Now we're really talking about all of the information necessary to really care for this group of patients. And we actually have teams working with us now to figure out how do we codify social service information? How do we cull from an electronic narrative issues that would have to do with domestic violence, with patients who are on the brink of being undomiciled, all the things that are going to affect their future. And it's quite an exciting opportunity and quite a challenge. But that's, in fact, what we are trying to do right now. We actually have teams coming in from literally all over the world to help us try to figure out how to construct and codify all of this information in a usable fashion, how to then develop decision support rules to care for this group of patients. So if you use your imagination, I think you can see how beautifully this really applies to the discussion we're having today. So what's the future? We're going to see expansion of these information exchanges. We have 5 in New York. Do we really need 5 in New York? No. They're all going to have to speak to one another in very short order, and we're going to have to determine what is really necessary to make sure that the data gets transmitted as needed by all of us and by all of the patients we serve, and the patients themselves with the patient portal. But we certainly won't need separate organizations for all of it. We need to develop more in the way of comprehensive clinical decision support. As I said, weaving in new sources of data and new types of data is a challenge, but really is important. We have to improve the coordination and communication between all of our agencies. The one thing that is really exciting about what's going on with our HEAL 10 and now HEAL 17 project, which we've merged, is we have 16 organizations all aligned and all in agreement. These are organizations that really didn't talk to each other before. But everybody is on the same page because we're all interested in caring for the same population and realize that we rely on one another every day. We are going to need to develop new training programs. We are going to need new kinds of health workers who are computer literate, who can take this information, who can track patients and navigate. It's, like I said, not sufficient to just provide data bits. You really have to provide actionable information. You're going to have to provide some staff to take action as well. And then finally, and Brett talked about this really at length, we really need to develop an economic model that sustains it. We have to look at all of the things coming out of both Albany and Washington and figure out how to capitalize on what's a shrinking pot, but nonetheless real money, to make sure that what we have to do can actually happen. There